Hello everyone. Today we'll be talking about chair-side investigations in dentistry. This is the Department of Oral Medicine and Radiology, and I am Dr. Sundur. Before we start the topic, we first need to understand what investigations are. So investigations are nothing like we do physical examinations in the same way when we are collecting tissue, blood or other specimens which are obtained from the patient, and then they are sent for biochemical, microbiological, microscopic or immunological examination. Then those are called as investigations. Investigations can be of two types. The first one is chair-side investigations and the second one is lab tests. So chair-side investigations is our topic for today, and as the name suggests, it tells us that these are the investigations which can be done on the chair side while the patient is sitting on the chair. So there are various categories that we'll be covering in that. The first one is pulp vitality tests, the diagnosis of tooth fracture, plaque disclosing agents, caries detection, diagnostics and early detection of precancerous lesions, exfoliative cytology with fine needle aspiration as well included, salivary flow test, diascopy test, diagnostic nerve block, culture and sensitivity test. So we'll be talking about all of these individually and we'll understand how do we do these and what kind of results will they give us. So, what is chair-side investigations? These are simple tests and examination procedure which can be performed easily at the chair side. So, the first one is pulp vitality test. These tests will tell us if what is the vitality of the pulp. Okay. So, what are the different cases in which we'll be doing this? So, first when you have to check the pulpal health that is there in question, if we think that the tooth is vital or not vital for that, and if there is any orofacial pain which is there, is it due to the teeth or is it due to the other factors, other structures that are around, or it can be when there has been a trauma to the pulp. Then we want to see if it's still vital or not. Then after we have given anesthesia, we want to check if the tooth has become properly anesthetized. Then we can also do the assessment of the teeth which have been pulp capped or which will require deep restorations. We need to see if it's vital or not. Okay. The disadvantages are that the test can be difficult to use on the posterior teeth because we know there is limited access in the backside of the teeth. Then there can be excessive heating which can cause pulpal damage. There are certain conditions where false positive responses will also be generated, like when there is excessive calcification in the pulp canals, or it's a recent trauma case, or the patient has been taking pre-medications, analgesics that they have been taking, or the apex is immature and it's an open apex. Then there are different methods of pulp testing. There are conventional methods which are easier and which have been followed for a very long time, and there are certain advanced methods as well. Conventional methods are thermal pulp testing, electrical pulp testing, test cavity and anesthetic test. We'll be talking about all of them, how are they done and what is used to do these procedures. And then there are advanced methods of laser Doppler flowmetry, pulp oximetry, dual lens spectrophotometry, Hughes probe camera, transillumination and plethysmography. So the first one is thermal pulp testing. So as the name suggests, thermal is the heat or the cold test that we'll be doing, and we'll see the response of the pulp, uh, of the inflamed pulp, and that will give us more accurate results. Okay. So during cold testing, what happens is when we are applying anything cold on the surface of the tooth, there are dentinal fluids which are there in the dentinal tubules. There is a rapid outward flow from these tubules which will cause hydrodynamic changes in this fluid that will activate our A delta fibers. Okay, because of the A delta fibers, this movement that it's detecting, it will lead to a sharp sensation which will last as long as the stimulus that we are applying is there. Okay, so for cold testing, the different things that we'll use is ice sticks. We can use normal ice cubes. We'll wrap it in a gauze piece and then we'll apply it to the buccal surface and see what is the response. Okay, and to get an authentic result, what you have to do is we'll have to take it on one side and then we have to compare it to the other side, normal healthy tooth, to see the response. Okay, there shouldn't be a lot of difference between the two. Okay, then there is carbon dioxide snow or dry ice. Okay, so there are solid sticks of carbon dioxide gas which are available. We can apply it on the buccal surface of the tooth, and they are used where there are full coverage metallic restorations that will help us in giving results in those cases. Then there are various compressed gases like ethyl chloride and DDM which can be used. They can be sprayed on the cotton pledget as you can see in the picture here, and then they can be applied on the uh, surface of the buccal surfaces of the teeth, and then compared, always compared to the contralateral side to check if the readings that we are getting are similar or not. We can take adjacent tooth also, we can take 2-3 tooth and then we can compare what is the normal healthy response and what is the response of the diseased tooth that we are suspecting of. Then a very easy method is using ice cold water. So what we'll have to do is, here we need to isolate the particular tooth of concern. So we'll have to use a rubber dam. We'll isolate that particular tooth, probably 2-3 more, one adjacent and one contralateral as well, so that we can compare it. So we'll fill the syringe with ice cold water and then we'll put it on the tooth and then we'll elicit the response. The mechanism of cold test, in the same way there is the mechanism of heat test, where when we are applying a stimulus as a heat, then there is rapid inward flow of the fluid that will cause hydrodynamic changes and the A delta fibers will be activated and it will cause a sharp sensation. Okay, so methods of heat testing are very easy. We'll take a GP stick and we'll first coat the tooth with petroleum jelly so that GP doesn't stick to the surface of the teeth. Then we'll warm the GP and place it on the facial surface, the middle 1/3, and we will see the response within less than 2 seconds. Okay, it will be generated. If we are applying it for 5 seconds, then uh, the temperature at pulpodentinal junction less than 2 degrees will be seen. We can also do like the cold water bath test that we've done. We can do it same with hot water. We can do the same way, isolate the tooth and then we'll check the response within 5 seconds. Here we'll have to take hot water. Then there is electrical pulp test or the EPT. Here the stimulus that is applied is in the form of electric current on the surface of the tooth and that will activate the A delta nerves. Okay, so it is a battery operated instrument and it is connected to a probe which is used to uh, contact on the surface of the tooth for investigations, and it should be at a very low value so that we don't have a lot of excessive stimulation and discomfort for the patient. And the intensity of the electrical stimulus is increased steadily, not very rapidly. We won't skip, we'll increase the electrical current value one step at a time. Okay, but it is not a very quantitative measure of pulp health, but it does tell us about the health and function of the A delta fibers within the pulp. So how do we do it? First, we inform the patient. Otherwise, there will be a lot of anxiety that will be there and there will be mistakes because we have not educated the patient about it. So we will tell them what are the things that we are going to do and how they have to sit, and they don't have to jump. As soon as they feel the response being generated, they can lift their hand and then we can understand that okay, it's the response being generated already. Okay, so we isolate the tooth and then we can use rubber dams or cotton gauze. We'll dry the surface of the tooth and then there's a metal clip which is there. We'll hang it at the corner to complete the circuit. If the metal clip is not available, we can ask the patient to touch the tester probe so that the circuit is completed. Then we'll apply a certain conducting medium on the surface of the tooth or we can apply it on the test probe, the tip of the test probe. And then what we are going to do is we are going to place the tip on the teeth at the middle third of the posterior teeth and incisal one third in the anterior teeth, and we'll make sure that the gingiva is not contacted. Then we'll initiate the delivery of electric current to the tooth. One step at a time will increase, and we'll note the readings that the pulp tester is giving, and then we'll compare it to the normal adjacent teeth. Then what are the disadvantages of using this? These can't be used on cardiac pacemaker patients, and it does not tell you full-fledgedly about the integrity and the health of the pulp. It just tells us if there are vital sensory fibers in the pulp. Okay, and it does not tell us about the vascularity of the pulp, which is one important factor to decide the pulp vitality. There can be certain places where there can be false positive responses, as I told you, when you're not educating the patient about what the procedure is going to happen. Then the patient can be very anxious, or if you're not isolating, then there can be saliva contamination, or with the gingival tissue we can have that problem. If there are metallic restorations, it can't be used. Okay, and the false negative responses will be in the immature teeth, the trauma cases, pre-medications, or poor contact with teeth, or inadequate contact is there, or partial necrosis of the white pulp has been already done. Then an obsolete method, not used at all now, test cavity, where what you do is to find what the problem is, you keep drilling, and the tooth is unanesthetized, and we drill the tooth at slow speed without a water coolant, and then we check for sensitivity or the pain, which tells us about the vitality. Okay, and if the pulp is necrotic, then pulp is already dead, so we can do the endo treatment without having to give anesthesia. The patient will not feel any kind of pain. Okay, anesthetic test, another obsolete method where we don't use it too much. What we do is we'll anesthetize a particular tooth that we think is the causative factor of the pain, and we'll wait, and then we'll ask the patient if the pain has subsided, does it not hurt anymore. If they say that okay, it's not hurting anymore, it means that that particular tooth was the reason of complaint. Okay, and if it is not, then we go move on to the next teeth and move on to the next teeth until we find the causative reason. Okay, but not very acceptable by the patient. Then a very widely used technique is pulp oximetry. Okay, here what we are doing is we are recording the blood oxygen saturation level, okay, while we are doing the administration of IV anesthesia. By measuring changes in the oxygen saturation, pulp oximetry is able to detect the pulpal inflammation, or even if there is partial necrosis in the teeth. Even if the full teeth is not necrosed, only a part of it is there, then it can help us. So what happens here is a pulp oximetry uses a probe which has a diode emitting two wavelengths of light, the red light and there's an infrared light. There's a photo detector, and that is placed on the opposite side, and it detects the light once it is passed through the tooth. Okay, so the advantage is that it is very effective and an objective method, and in case of any impact injury that has happened, the blood supply is intact but the nerve supply does get damaged, so we can check for that. Then pulpal circulation detected independent of the gingival circulation, so we're not taking the gingiva's circulation in to understanding. And the pulp pulse readings are reproducible, they can be repeated over and over again, it will give you the same response. And the oximeters are very small and cheap, easily available, and can be used very easily. But the drawbacks are some background absorption with the venous blood flow is also there, so we cannot differentiate it. The probes should be specific for the anatomy of the tooth, as oxygen saturation level will be different, lower than the reading from the patient's finger if we're comparing it to that. So how does that work? The probe is placed on the labial side of the tooth surface and the sensor on the opposite side. Okay, just like we're doing an X-ray where the X-ray tube is outside and the sensor is inside. In the same way, that is how it's happening. The light, either red and infrared, both are made to pass through the tooth. The oxyhemoglobin which is there, it absorbs all the infrared light and the red light does not get absorbed. Okay, while deoxyhemoglobin absorbs the red one. Okay, so the vital tooth which is more vascular, a red light is detected. Okay, and if the tooth is non-vital, then the infrared light will be detected. So this device will compare the ratio of amplitudes of the transmitted, the infrared light and the red light that will be uh, detected on the sensor. Okay, then there will be a graph that will be produced that will tell the oxygenated hemoglobin level and the deoxygenated hemoglobin level. Okay. The next one is cracked tooth syndrome. So cracked tooth syndrome, as you can already understand from the term, is there might be a fracture of a vital tooth that may have happened, which is extending to the dentine, probably also extending to the pulp. Okay, the symptoms that the patient will come to you with is sensitivity to cold, and when they are releasing pressure after biting on any food or hard objects, then the pain is being experienced. There will be the same symptoms of pulpitis when the pulp is involved, and periodontal disease will also manifest if the fracture is extending to the root portion of the tooth. The mandibular second molars are the ones which are more prone to this than the mandibular first molars, and then the maxillary premolars, which will be commonly affected. Now, how will we diagnose a cracked tooth syndrome? First, we'll take a dental history. Sometimes it works wonders when we ask the patient and they will tell you they were biting on something hard or they were doing opening some can bottles or something with their teeth that has caused that. Then we can use the visual examination method, also tactile examination. Then there's a bite test that can be done. We can use trans illumination, and there are certain stains that can also help us diagnose it. So when we are asking the patient for dental history, then we can ask them about their dietary habits or any treatments that they have had earlier, or there has been certain accidents or trauma that have recently happened. Do they have a betel nut chewing habit, or they have any parafunctional habits? Okay, that will help us to decide that it may be a case of cracked tooth syndrome. Then we can use magnifying loops for visual examination, because to a naked eye the tooth is already very small and the cracks are going to be way smaller, and they might sometimes go unnoticed if we are trying to observe it with our naked eyes. Then there's tactile examination, where we are taking the sharp end of the probe and running it around the tooth surfaces. There will be a sudden click sound in the place of the fracture line. Okay. To check for the bite test, we can use rubber wheels, wooden sticks, or tooth slot, and they can be placed on the cusp of the suspected tooth, and we'll ask the patient to not push too much pressure when they're biting, and then we'll ask them to release. If there's pain during biting or during releasing the pressure, then it means that it is definitely a case of a cracked tooth syndrome. If the pain is only there on biting, that it means then it is apical periodontitis. If if the pain is there on releasing pressure, then it is also suggestive of cracked tooth syndrome. And if the pain is relieved when they bite on it, then it is periapical abscess. There is a fract finder, the photo that is given of a tooth slot, which can be used for individual cusps as we ask the patient to bite, and then we can find the selective pressure on one of the cusps and we can find which particular region might be having it. Another method of checking for cracked tooth syndrome is trans illumination. Okay, a fiber optic light has to be used along with magnification by using loops to check for this. we'll have to clean the surface of the tooth. We'll take a fiber optic light and we'll touch the surface of the tooth, and if there is no fracture, then the light will pass through and through the surface of the tooth. But if there's a fracture line, as you can see in the picture, the light will be obscured from going forward. Okay, composite curing lights are not recommended. Okay, and if the tooth has a restoration, then we should try to remove all of that restoration so that we can expose the fracture line. That way it will be easier for us to diagnose. Then there are certain dyes that can be used, like gentian violet or methylene blue stains. They will highlight the fracture line and make it easier for us to notice them. But the disadvantage is that it takes at least 2 to 5 days to be very effective, and it requires that you place a provisional restoration, and the placing a provisional restoration usually undermines the structural integrity of the tooth, and it might cause more of that crack to progress. So not highly recommended. Now we are done with cracked tooth syndrome, and then we move to plaque disclosing agent, which is another chairside investigation. Dental plaque, it deposits on the surface, and if it is not treated, then it can cause a lot of destruction to the tissue and there can be loss of attachment. Dental plaque is totally transparent, colorless, and it is not easily visible, which is why we have to use plaque disclosing agents to identify the areas where the plaque deposition is evident. These can be in the form of selective dyes, tablets, or lozenges, where not only can we see it, we can also educate the patient and show them what is their maintenance of plaque on their teeth. Okay. So there are different plaque disclosing agents: the iodine preparation, mercurochrome preparation, Bismarck brown, merbumine, erythrocene, fast green, fluorescein, two-tone dyes are there. Okay, so there are a lot of things which are available in the market. What is the purpose of doing this? We can detect plaque on the tooth, what locations they are present. We can also educate the patient, as I already told you. We can see that the products or the procedures that the patient is already following to maintain their oral health, is it working or not. Then we can also detect regular, irregular, and rough surfaces where they are more prone to taking up these stains because there will be more plaque deposition there. And we can use this to motivate the patient to practice better oral hygiene, and the patient can also use it for their self evaluation. Okay, so what are the different methods that we can use? We can use the first method of painting. We ask the patient to rinse uh, the mouth so that all the food particles or the heavy saliva that is there, it can be washed out. Okay, we'll apply a water-based lubricant to prevent staining of the lips, because these can stain the teeth. It will become uncomfortable to the patient. We'll dry the tooth with compressed air. We'll retract all the tongue and the cheek. We'll use cotton pallets to carry the solution, and we will coat it on the crowns of the teeth. Okay, we'll ask the patient to spread the agent on all surfaces with the help of the tongue as well, and we will examine if it has spread on all surfaces. Okay, and if not, then we can ask the patient to rinse. Okay, rinsing is another method where a few drops of the concentrated preparation is put in a paper cup, water is mixed with it, and then we ask the patient to rinse, swish, and throw the solution out, so the entire tooth surfaces will be covered. There are certain tablets or wafers. The patient chews half a wafer, then swishes it for a minute and then rinses it off. Then it will be easily visible. So if the tooth comes out totally clean, it means the coloring agent was not absorbed. If there's pellicle, then there is a thin, relatively very thin stain which will be there. If there's plaque, then there will be darker areas, more opaque areas will be there. And if the two-tone dye is used, then the red one, a red biofilm that will be there, it will tell us about the newly formed plaque, and the blue one will tell you about the older tenacious plaque, okay, below the subgingival margins. Then another method of chairside investigation is caries detection, which is our bread and butter, right? So caries is something that happens to the patient and they are definitely coming to us for it. Okay, so whenever we see that, first what we do is we always go for the conventional method of visual examination. We use trans illumination. Then these are all non-radiographic methods. Then after that, to confirm it more, we go towards the radiographic methods. Okay, so the non-radiographic methods are tactile examination, visual examination, and by use of dyes. The advanced method are the use of fiber optic illumination, digital imaging, fiber optic illumination. Then there are some lasers that can help us detect. The diagnodent is also there. Okay. Then we have radiographic methods where we are taking IOPs by doing zero radiography, and now in a more digital era we are taking digital imaging. Okay. So tactile examination, we always get our mouth mirrors and probe, and we try to probe through and see the decay which is there, what particular tooth, which particular surface of the tooth is involved. Okay, and use of sharp explorer tips in pit and fissure caries are usually not encouraged, because if you are scraping it out and pushing it too much, then we can exaggerate the response and the bacteria may penetrate further. Then visual examination, we always use our eyes to visualize what surface of the tooth has caries. Okay, and it does not has a lot of harmful effects like with our probe where we are deepening our cavities. Okay, but sometimes what happens is if the lesions are very small, they sometimes do go unnoticed by us. Okay, and sometimes the pit and fissure, they are normally stained. Some people have it, healthy teeth have it, and we sometimes confuse it with pit and fissure caries. So that is one disadvantage. Then there is ultraviolet illumination, where the natural fluorescence of enamel as seen in the UV light, where there is less mineralized content in a carious part, they will help us to diagnose, because the caries will appear as dark spots. The advantage is that it is a more sensitive method as compared to the visual and the tactile method, and the results are more reliable. The disadvantage is that it is difficult to differentiate developmental defects and caries with that, and it cannot be quantified. Then the fibro-optic transillumination, it results in the opacity of demineralized tooth structures over more than the translucent healthy structures. The decalcified areas will not let light pass through as it does in a healthy area. Okay, that will lead to a formation of a shadow. The advantage is that it is non-invasive, and even if the patient is having crowding, then it is very useful for us. There is no radiation exposure because we are using just a light source, and it is comfortable to the patient. The disadvantage is that not possible in all the anatomic locations, and sometimes the observer variations may be there. The digital fiber optic trans illumination, the dye photi, it is very similar to the photi, but here a CCD sensor is used, and the data that is recorded is sent to the computer, which it then analyzes and helps us detect the caries. As you can see in the picture here, the tooth is here, the light source is going, and in the sensor, this part, it will be seen on the sensor as a caries, small caries which is there. Okay, it is non-invasive, and even very initial caries can be detected, so it's good for us. But the disadvantage is that it will not tell us the depth of the carious lesion. Okay, and the stain, pit and fissure also it will not be able to differentiate. Then dyes like they are used for plaque disclosing agent, in the same way they can be used for our caries detection also. So these detector dyes, they will help us to detect the depth and the surface of the demineralized area. Okay, then the procyon dye and calcine, basic fuchsin, it is all used. And the advantage is that of course it's non-invasive and a very easy simple procedure. Okay, but there are certain dyes which are carcinogenic, so not preferably used. Then of course we go to our radiographic methods, okay, where we're using the X-ray radiation to detect caries. They will be detected as radiolucent structures on the radiograph, telling us about the amount of demineralization of the tooth that has occurred. So we can take IOPs and wide ring radiographs, and the lesions which are there in the proximal surface, which sometimes are not visually seen, then these are very good diagnostic methods for that. But the disadvantage is that because it uses ionizing radiations and it requires a machine setup and equipment is required, that is why that can be one thing that is an issue for it. Then the digital era has introduced CCD, CMOS and PSP sensors which are used, and the radiation dose is comparatively very low, and the enhancement and the enlargement, we can adjust our contrast, we can store all of that digital content for later on, and the chances of the faults of scraping and all that is not there, and a processing equipment setup is not required. But then the cost becomes more effective and the sensors need to be handled properly. Sometimes the sensors are a little stiff and difficult to place in the patient's mouth. Then we have Diagnodent. It is a device that emits red laser light which is absorbed by the tooth, and then it fluoresces, which is captured by the detector probe, and then it is transferred back to the machine where it reads it out. Okay, if the reading comes to 0, that means there's no fluorescence, and 99 is the maximum reading that will come. Okay, the fluorescence will be more and in parts where there is caries. The advantage is that it has good reproducibility and it confirms the healthy tooth structures before the sealants are applied. Good patient education tool, and removes all kinds of doubt about any hidden caries that are there. But then it's a little expensive and it is also sensitive to stains, and it can also give you false positive results as well. Now, a very simple, easy method is biopsy. Biopsy is where we are removing living tissue for the purpose of microscopic examination and for diagnosis. There are different types of biopsies that can be done. Incisional biopsy, excisional, punch, brush biopsy, FNAC, bone marrow biopsy, shave biopsy, curettage, laser biopsies, that can all be done. So where is biopsy indicated? It is indicated in places where the lesion has been there for more than 2 weeks and we cannot find the reason why it has happened. Okay. Or if there's an inflammatory lesion which is there since more than 2 weeks, even after you have removed the causative etiological factor for it, it's still there. Then the mixed red white lesions, and to find if they are benign, malignant or precancerous, we should go for it. And ulcers that haven't healed for more than 3 weeks, definitely go for it. And if there is a persistent swelling that is there without any clear-cut diagnosis, then for those cases, then certain benign conditions which are interfering with the local function and the patient feels uncomfortable because of that, in cases of fibroma, papilloma, mucoceles and pyogenic granulomas. Okay, because these you can just visualize and find out that these are these. To diagnose and determine specific types of neoplasms and the lesions which are not responding to any of the treatment modalities. Okay, they are contraindication, they are contraindicated where we should know about the normal anatomic features, which are which can be also some racial variations where we should not go for biopsies. If the inflammatory condition is very acute in a bacterial or a viral condition, we will not go for it. If we are definitely sure of this lesion being a malignancy, then we don't want seeding of the cancerous cells. Okay, so we will not biopsy that area. And if the lesion that is there is very close to an anatomic structure where it can cause more harm than benefit, okay, infrabony lesion should not be biopsied, okay, unless aspiration has been done. And pulsative lesions where they are AV malformation or hemangiomas not to be biopsied, because there will be a lot of bleeding, will not be able to uh, control that. And if the patient's health isn't very good, they have a compromised health condition, and they might not be able to heal that small biopsy procedure that you are doing. Then for incisional biopsy, what we do is incisional or a diagnostic biopsy is if there's a big tissue, and we take just a small part of that lesion and we make sure that a part of the normal tissue is also there in our section. Okay, if the size is more than 1 centimeter, we just take a part of it. Okay, so that we can send it to the lab and find out what it is. Okay, and that is how it's done. Then excisional biopsy, if the lesions are smaller in size, the entire lesion will be cut out and then sent for examination. Okay, these are for smaller lesions. Okay, and the lesions which appear benign like irritational fibromas, mucosal papilloma, pyogenic granuloma, when you're sure of these lesions being there, of course you'll go for excisional biopsy and remove them out. Okay. Here also, like in incisional biopsy, make sure you include some of the normal tissue along with the lesion that you're biopsying. Then punch biopsy, a very easy method where we take a punch which has a circular blade and a plastic handle. These are disposable. We just these are also for smaller lesions. Then they will cut away that part of the lesion and then they can be sent. Then fine needle aspiration cytology and fine needle aspiration biology. Here a needle or syringe is used to go within the lesion, and then the plunger is withdrawn as we are exiting out of the lesion, and the plunger is also moved in all of the directions, and then we push whatever tissue sample has been collected and then we put it on our slide. They are smeared and then sent for examination. Okay, the lesions that contain fluid or intraosseous lesions, okay, so that we can rule out vascular lesions, we'll do this first before we biopsy of intraoral incisional and excisional biopsies. Okay, it's painless and helps to understand the lesion, nature of the lesion without causing a lot of discomfort to the patient. It's not very expensive and there's low risk of complications. Okay, patients who have debilitating conditions which might not be able to heal from it, it's a very good technique. Then the procedure is that when we are aspirating fluid, we insert the needle, aspirate, see the color and the contents of the fluid, and then we send it for examination. If we are removing tissue by the biopsy of a needle, we insert the needle, aspirate, do back and forth movement, release the negative pressure, and the needle and the syringe is separated. Then the air is drawn into the syringe and then needle is attached. Then the contents will come out, will fill up into the syringe and we can stain it and see it on the microscope. So if the fluid aspiration is done and we are not able to aspirate any fluid, it means it's a bony lesion. Okay, and they can be suggestive of osteomas, fibrous dysplasias, or ossifying fibromas. If a straw colored fluid is obtained, it's a cystic lesion, probably a radicular cyst or a dentigerous cyst. A brownish or straw colored fluid with blood is seen, then it is an infected cyst. Infected radicular cyst or infected dentatorous cysts are commonly seen. Okay, if it is a thick creamy fluid, then it is definitely a cystic lesion, probably suggestive of an OKC. If there is aspiration of pus, that means it's inflammatory or infectious process, and it is a palatal abscess or a submucosal abscess. If we aspirate blood, then it's for sure a vascular lesions. Okay, never to be biopsied. If we are aspirating air, there is no fluid, then it can be suggestive of traumatic bone cyst or static bone cyst. Okay. Then the brush biopsy, we take a brush which captures all the epithelial cells, and then as the slight bleeding is noticed, we take all of that cellular aggregate which is there on the blood on the brush, and then we transfer it to the slide, and then they are analyzed. Okay. Lesions which are red and white lesions that require long-term follow-up and chronic ulcerations, okay, those are the ones that we'll go for. And the contraindication is that the lesion with intact normal epithelium will not be done with this procedure. Interpretation is, if no epithelial abnormality is there, then it will be negative. If the test comes out as atypical, that means abnormal atypical changes of certain diagnostic importance was seen. If it is positive, then it means that the cells show dysplasia and carcinoma. And if it's inadequate, that means the specimen that was collected wasn't good enough. We'll have to repeat the test. Okay. The advantage is that it is does not require anesthetics. It's very comfortable for the patient, very easy, and doesn't require a lot of investment. Okay. But the drawback is that it will not tell us anything about the connective tissue or the pigmented lesions, and sometimes it's not very adequate. Okay, if the samples or specimens are not adequate, then the results will not come out fine. Then we have exfoliative cytology. Here what we do is we try to scrape off the upper surface of the cell. The epithelium is what we collect, and then we send it, we rub it on the slide, and then we send it for examination. It can be done for herpes cases and pemphigus, white spot nevus candidal infections, red and white lesions. Okay. So the procedure is to clean the surface with of any of the food debris that is there. Then we vigorously scrape with a tongue blade or a metal cement spatula, and the materials that are collected, we put it on the slide and we fix it, and then we examine it under the microscope. Okay. Normal cells are observed, then it is class 1. If atypical cells, then but there is no evidence of any malignant change, then it is a class 2 case. Class 3, if no clear-cut suggestion of cancer, but precancerous lesion may have been validated, so biopsy is recommended. Then if it is suggestive of cancer, then it will be class 4. Okay, the cells that were collected showed malignant potential characteristics. And class 5 is the one where it is totally positive for cancer, and it has malignant cells, so the biopsy is recommended to check how much of the extent has been involved. Okay, we don't want further spread. Then the advantage is that it is just an adjunct to biopsy. It will never replace biopsy. It's quick and simple, and it is not very costly. It is a screening method. Okay, but the limitations are that the presence and extent of invasion cannot be accessed. Negative cytology does not rule out cancer. Then we come to saliva collection methods. Okay, saliva collection methods is for the flow of the saliva. Okay, where the salivation has been reduced, we'll check for biochemical immunological changes, and we can collect mixed saliva, stimulated saliva, unstimulated saliva, or particular the individual major glands that are there. Okay. uh, Collection method, unstimulated saliva, when I use the word, it means that I am not doing anything to cause more saliva to occur. Okay, so we'll advise the patient to not eat or drink before this procedure is to be done, at least 1 hour before. No smoking, no chewing gum, okay, no beverages. And we ask the patient to rinse their mouth with distilled water, and we ask the patient to sit and relax. We tell them to swallow first and then we start, and make sure the patient is not moving too much. There are different methods of collecting unstimulated saliva. In collection of stimulated saliva, the same instructions will be given, but here we'll be using some stimulating agents. It can be either paraffin or citric acid solution, okay, or we can ask the patient to spit to induce that spitting of the saliva, okay. So draining method is one method of collecting both stimulated and unstimulated. Here the patient is asked to allow the saliva to collect, and then they tilt their head and do it in measure it in the weight cylinder by tilting their heads. It is a reliable and reproducible method, okay, and this saliva that is collected can be used for DNA analysis. The disadvantage is that there can be evaporation of the saliva from the cylinders that is there, and sometimes it's not very comfortable for the patient to keep spitting it out. Then we have the spitting method, where the patient is allowed to collect all the saliva in the floor of the mouth, and then after every 60 seconds for at least 5 minutes they are asked to keep spitting the saliva, okay. It can be used for both stimulated and unstimulated saliva, but it is not a very reliable method, as when we are doing it for unstimulated saliva, we are sort of putting a certain stimulation, so our data that we obtain will not be very accurate. Then the swab absorbent method will take pre-weighed gauge, then we'll place it in the patient's mouth for a particular amount of time. The sponge will soak up all the saliva, and then we measure the weight of the sponge again, and then we can minus that out to get how much amount of saliva that has been produced, okay. But the disadvantage is that it is less reliable than the draining method, and some of the concentration of the saliva component may not be very accurate. Then we have a suction method, where we are using an aspirator or a saliva ejector to draw saliva from the mouth into a test tube, and we do not require much cooperation from the patient side, but then it is not a very reliable method as compared to the draining and the spitting method. Then we have another method of using calcium cretendin cups, as you can see in the picture here. Here it is placed in possession of the parotid gland. So whatever secretions are being produced, it will be collected in this very accurate method of collecting saliva, but a little expensive to obtain. For the submandibular and the sublingual glands, there are certain alginate held collectors called as the segregators, which can be positioned at the floor of the mouth. Then it has a tubing system which collects in the pre-weighed vessels, and orthodontic cribs or clasps can be used to enhance the stability of this. Minor salivary glands, there are capillary tube methods and the filter paper method that can be used. The capillary tubes of microliters can be used to collect from the everted surfaces of the lower lip wherever our minor salivary glands are present. And the filter paper method, sterile 2 mm filter paper is used, okay, and that will absorb and then we can see. The next one is our diagnostic test for whatever vascular lesions that I come across. We'll use this test. What we do is we take a glass slide over a vascular lesion and we try to put in pressure with this glass slide. As you can see in the next picture, you see that it became a little blanched. It means that when you're applying pressure, then all that blood is spreading out on a application of pressure. So that will tell us that this is a hemorrhagic lesion or a vascular lesion. If it's a non-vascular lesion, the diagnostic test will become negative. Then we have diagnostic analgesic blocking. So it is very similar to our anesthetic test where we were using it particularly for the tooth, but here we need to be very skillful and understand the positioning of the different masticatory muscle systems and the TMJ. So we can use anesthesia, and if you are suspecting of a TMJ problem, we can anesthetize that part or a particular muscle which is causing that pain. We can use that diagnostic nerve block and see what is the response of the patient. But then these are contraindications are that in cases of acute cases of muscle injury, trauma or pain, it will not be used. Allergy to anesthetics, people who are allergic to it, not be used. And people who have anticoagulants, they will not work through this method, and if there's cellulitis in the particular area. Okay. These types and significance of the diagnostic block is that if it is a maxillary nerve block, mandibular nerve block or INV, we can find if the pain was from that particular region. Okay, if muscle injection is something that we are doing, it can be used for treatment of MPDS. Okay, so masseter temporalis, the particular muscles, lateral medial pterygoid, all of that will be injected. Then in the intracapsular regions of the TMJ, if it is a source of pain, then the injection can be directly done there. And the pulp vitality testing of anesthetic test, we have already talked about it. Then there's something called as the patch test. Okay, if a patient is particularly allergic to a particular food item or a drug, then there will be type 4 hypersensitivity reactions which will be seen. So it is indicated in patients who are having allergic contact stomatitis with particular things, maybe restorations also, or metal prosthesis. Okay, allergic contact cheilitis or oral lichenoid reaction, burning mouth syndrome, orofacial granulomatosis, aphthous ulcers, angioedema. So here the patch test can be done because there might be a particular causative agent that is causing that allergic inflammation of the patient's skin or mucosa. So we need to find what that out, and we have to eliminate that. To check for a single allergen, we will first ask the patient to not be taking any immunosuppressive medications for at least a week before the testing takes place, otherwise we'll get negative results. We'll take that suspected allergen in a petroleum jelly base, put it on a filter paper and then put it on the upper back region. Okay, it is left for 2 to 3 days and then the reaction that is elicited is noted. If you are checking for multiple allergens, then tiny quantities of 20 to 50 to 100, 150 allergens, they are placed on individual square plastic boxes in aluminium chambers and then applied on the upper back. They are kept in place with adhesive tapes and the patch is left undisturbed for 2 to 3 days, and then we check if the hypersensitivity reactions have occurred. Then the test, if there is no reaction, it means it's a negative test. If there's a minor reaction, that means there is certain amount of irritation of the skin which is happening because of that particular uh, thing that is causing it. Then if there is an elevated ring, red or pink plaques, then it is a weak positive response that is generated. If papules or vesicles are formed in that particular region, it is strongly positive. And if there is severe redness, itching, blisters or ulceration, that means that the person is extremely reactive to it. So with that, we finish off our chairside investigations. And if we have to just give a glimpse of whatever things we had read, the first one, what do you think it is? It is our thermal testing with ice. Okay. The second one is GP sticks for thermal testing. The third one is our electrical perk testers. The fourth one is for checking the cracked tooth syndrome of by using a tooth slot. The fifth is plaque disclosing agents, where we are using dyes to educate the patient and to see what areas of the tooth have more plaque deposition. The sixth one is a caries detecting dye. Okay. And the seventh one is where we use our tactile examination for caries detection. We'll not do that in Pitt and Fisher caries. Then the eighth one is the calcium creatinine cup, which is used to collect the stimulated and the non-stimulated saliva. The ninth is using the brush biopsy, okay, to collect the epithelial cells. And the 10th one is our diascopy test, okay, for vascular lesions. Um, and thank you.